Okay, the first study that I'm talking about is about niraparib maintenance therapy in ovarian cancer, in platinum-sensitive recurrent ovarian cancer. And this was a very important study because this is niraparib is a PARP inhibitor, and this study found that it significantly reduces the risk of progression-free survival. And the most intriguing thing about this study was we usually know PARP inhibitors to be effective in those cancers that have germline BRCA mutation, but in this study we found that niraparib was effective regardless of the presence of the absence of BRCA mutation. But there are some caveats to implement this study into your clinical practice. Number one, we don't have data on overall survival. These positive findings are only regarding progression-free survival, and the progression-free survival is quite substantial in this case. So most likely it can translate into overall survival benefit. But another thing to consider is the increase in toxicity with the use of this agent was not negligible. It was substantial. So we need to have a proper discussion with the patient, and the absolute increase in benefit is of course higher in case of those who have BRCA mutation compared to those who don't. So maybe for patients who have BRCA mutation, this is a very good treatment considering the balance of risk and benefit. But for those who don't have BRCA mutation, we need to have a proper evaluation of the risk and benefit of this agent. The second study was of course about immune checkpoint inhibitor, the famous thing in all major oncology meetings. And this is a study of adjuvant ipilimumab for melanoma. And this is a positive study again. The use of adjuvant ipilimumab significantly improved the recurrence-free survival, and this is quite an exciting study for melanoma, because in melanoma, in adjuvant setting, we do not have a good study that shows proper benefit, and the only agent we have is interferon, which has a lot of toxicities and very difficult to use. But in this study, I am disappointed with a few things. The most important thing that I didn't like about this study is the duration of treatment, because ipilimumab is approved for metastatic melanoma, and even in case of metastatic melanoma, we use only 4 courses of ipilimumab. But this is an adjuvant study. So these are patients whose primary tumor has already been treated with a local therapy, and you are giving adjuvant supplementary treatment in the hope of reducing the risk of recurrence. And they have used this agent for 3 years in this case. So you can imagine a person who has metastatic disease, who has disease, you give it only 4 courses and stop. And it is effective, it is an approved agent. But in this adjuvant setting, they are giving it for 3 years. And then they are finding a little bit of benefit. So if in my case, I would not be very comfortable prescribing this agent for 3 years, and it has substantial toxicities. Ipilimumab is not an easy to use drug. You need to be very careful about all the autoimmune side effects that this agent brings. And I would definitely not be comfortable using it for 3 years on anyone. Yeah, the third study is from breast cancer, and it's the study of ribociclib. And this was again a positive study, and this study found that with the use of ribociclib in the setting of hormone receptor positive advanced breast cancer, the risk of progression-free survival was significantly improved with the use of this drug. So this is a positive study, and the hazard ratio is also pretty good. But again, there are a few caveats. The first thing to understand is we don't have the survival data yet. The overall survival data are not mature yet, and it's more important in case of breast cancer, because from past experience we have seen with, although it was a different setting, we have seen that bevacizumab also substantially improved PFS, but later on it showed that there was no improvement in the overall survival. And in the setting of hormone receptor, but second line, we have everolimus. Everolimus also significantly improved progression-free survival. It has quite a big margin of improvement, but later again the overall survival was not improved. So like it's still open whether the use of ribociclib is going to improve the OS or not. And this is more important because the increase in toxicity is quite high, especially hematological toxicity. The neutropenia, grade 3 or higher neutropenia with this agent was nearly 59% compared to only 1% in the control group. So whether or not the patient is ready to accept 58% increase in the risk of neutropenia compared to take a drug that is not yet known to improve survival. The next study is of pembrolizumab. It's a Keynote 24 study, and in this study we saw that, and this was a positive study again, and this was a good study in the sense that it also improved overall survival. So with the use of pembrolizumab in the first-line setting of non-small cell lung carcinoma, we saw a significant improvement in overall survival with the use of this immunotherapy drug. And one important thing is that this drug in this trial was used only for those patients who had a PD-L1 positivity of more than 50%. So we do not know whether it will be effective for those patients who have a PD-L1 positive of less than 50% or who are PD-L1 negative. So we do not know that yet. But for patients who have PD-L1 positivity of more than 50%, now this should be a practice-changing drug in the first-line setting. And it's a very good study. And in this setting, nivolumab has failed. So I think Pembro has captured the market in the first-line setting of lung cancer, non-small cell lung cancer. But as I said, it is only for those patients who have a PD-L1 positivity of more than 50%. For nivolumab, also there was good news, because there was another study in head and neck cancer in the second-line metastatic setting, in which nivolumab showed positive results. And this study, what I liked about this nivolumab study is maybe they learned their lesson and they used a primary endpoint of overall survival and not progression-free survival. And because with the use of immunotherapy agent, we have heard a lot about pseudo-progression and progression-free survival benefit not being captured well by the REGIST criteria. So it's always important for any immunotherapy drug in a phase 3 clinical trial to have a primary endpoint of overall survival, because the immunotherapy benefits are seen a little bit later and after a period of pseudo-progression in some patients. So they did a beautiful thing. They used primary endpoint of overall survival, and it was a significant benefit. But if you see PFS, progression-free survival, in fact, there was no significant benefit. So if they had used primary endpoint of PFS, this should have been called a negative study. So it was a good thing that they used OS as primary endpoint, and this should also be practice-changing. And the last study is of adjuvant sunitinib for renal cell carcinoma. And this is a very intriguing study, and it really captured my interest, because we have seen a lot of studies of targeted agents in adjuvant setting in a variety of cancers, and most of them are negative. So the interesting thing about targeted agents is they work in case of metastatic setting, but you try to use the same drug in adjuvant setting after surgery, and they don't do very well. So we do not exactly know why. And this study was hailed as a positive study in adjuvant setting for renal cell carcinoma, and this is the first time that has happened for a targeted agent. And it is very interesting. But again, because all other studies of targeted agents in adjuvant setting have been negative, I'm a bit reluctant to yet incorporate this into or recommend this for clinical practice, because number one, we don't have survival data yet. This is just a data on recurrence-free survival. And number two, they have used sunitinib for 1 year, and I mean, sunitinib is a highly toxic drug. It is very toxic. And the patient they don't have a good time having this drug. And it's easy for a patient who has cancer, who has metastatic disease, to convince that the benefit is higher, so you need to take this drug. And even in metastatic setting, they usually take it for 6-7 months, by which time they have progression of disease, they have significant toxicities, and they try to skip this agent and they switch to a different agent. So how can I convince a patient who doesn't have cancer, because it has already been rejected? So he doesn't have cancer inside his body, and I'm trying to ask him to take a drug as toxic as sunitinib for 1 year in the hope of prolonging his recurrence-free survival. And I do not know about overall survival yet. So I don't think this should be a practice-changing thing, but let's see.